All right, so here's the deal. The leading cause of accidental death in the tri-state is not slipping and falling, getting out of the shower and cracking your head wide open and bleeding out because you hit your head on the toilet. It's not, messing around in the snowy ice winter joy of the tri-state and busting yourself wide open on the driveway because of ice and ugly conditions, because it feels like Calgary more than Cincinnati these days. It's not driving your car and having a mishap or something like that. It's not cooking and slicing yourself, with a knife as you're trying to chop up some stuff for dinner, choking to death on like a steak, or as I did years ago, eating a leftover pork chop as a kid. I was like 16 years old at the House of Sterling, and I'm like after school, eating the pork chop. I kid you not, this is what happened, and then I'm like choking. I'm choking out. So I'm like, oh, wait a minute, Heimlich, Dr. Heimlich. I can Heimlich myself on the back of a chair, and boom, I survive. Even something as mundane, and the danger is all around us. I see death everywhere. All those things I mentioned, and so many more inconceivable things out there, are not the leading cause of accidental death in the tri-state. The leading cause of accidental death in 2014 is heroin overdose. I'm going to say that again because it is disturbing. It is mind-numbing. It is frightening to me personally. Accidental death by overdose is the number one cause of accidental death in the tri-state. Someone who knows from said circumstance and all about issues associated with chemical dependency and treatment, getting healthy and clean and so forth, from CCAT, which is the Center for Chemical Addictions and Treatment, which is a pretty cool place that does a lot to help people in the tri-state, is a woman by the name of Angie, and she is here with me now on 700 WLW. Angie, how are you?
I'm wonderful. How are you, Sterling?
I'm pretty okay.
Good.
Help me understand how it is that, Angie Clark, what is I don't even know, how do we get to a point where heroin overdose is the number one cause of accidental death?
It's actually opioid overdoses in general. So it can be heroin, it can be morphine, codeine, methadone, hydrocodone. I mean, the list goes on and on. But yeah, there's a major problem with opioid overdoses in the area, and Ohio's death rate from unintentional drug poisonings increased 440% from 1999 to 2011. We have a real problem here, and 5 people die every day in the state of Ohio, and we lose about 1 person every other day in Hamilton County alone. And the costs associated with these unintentional fatal drug poisonings are about $1.9 billion each year. So we have opioid-related overdoses that have now reached epidemic proportions. It's a real problem here. It's
just really inconceivable, really. And we've talked about it a bunch. It's like beating a dead horse, arguably. Eddie and Tracy have talked about it. I've talked about it. Just about everybody on the radio here at the big one, 700 WLW, has talked about the heroin issues in the tri-state. And is it worse here than the rest of the country?
We've seen it's similar to a lot of the big cities. We have a really big problem here, but this has been going on in Boston and New York and LA and Chicago. So, they're seeing it in other cities too. I think that people were a little bit more surprised about it here. But yeah, we're definitely seeing it across the country. So CCAT has been working really hard to do a lot for the community to kind of help turn this around. And I know a lot of places, like in 1999, community opioid overdose prevention programs started distributing naloxone, which I'm sure we'll talk about, to bystanders and individuals who are at high risk for experiencing and witnessing these overdoses, so that we can start reversing, this epidemic of death.
Well, one of the things that you mentioned, this Narcan, I guess is the name that most people know, but it's naloxone, I believe is what it's pronounced as. And if
naloxone hydrochloride.
And this drug is basically somehow it defeats the action of the opiate when there is an overdose circumstance. So whether it's the emergency truck that shows up, the EMTs, whatever, it's law enforcement, it's the emergency room. maybe people who work in treatment situations like you guys do at the Center for Chemical and Addiction Treatment. These are the type of circumstances where this drug, in fact, can make a difference between life and death pretty quickly. And it's sort of, but not quite the same concept, if I'm not mistaken. Pulp Fiction is sort of notorious, for the scene, of course, where Uma Thurman decides to get a little taste of something. It's not what she thought. She ODs, and they do the whole deal traveling around trying to save her, and they get that huge hypodermic, effectively what it is. That's adrenaline or something like that to get her out of it. And Narcan really somehow nullifies the effect of the opiate. Is that exactly how it works?
It's a little different. It's a prescription medicine, and it reverses an opioid overdose. And it's a couple things that I want to say. It cannot be used to get high, and it has no addictive properties. Naloxone's safe, effective. We've been using it in the emergency room for decades. But what it does is it binds to mu opioid receptors in the brain, and it kicks out the drug, the opioids. And what happens is when opioids are attached in the brain, they cause this respiratory depression, which is, the most formidable symptom, which eventually is why the overdose becomes fatal. The drug kicks that out of the brain and kind of binds to it so it can't circulate, buying time so that people can call 911 and get the victim to the emergency room so we can continue to give Narcan.
Well, so basically your body forgets effectively how to breathe. That's the problem when it comes to the opiate overdose. I mean, is that a fair assessment?
Yes, absolutely. It inhibits your body's ability to breathe. And so what Narcan does is it come in and it just kicks the opioid out of the receptor and temporarily reverses that respiratory depression and buys time till you can get treatment at a hospital.
Now, a lot of people, because I've told them, they go, man, can you guys not talk about the heroin anymore? And why wasn't this being talked about, 3-4 years ago the way it is now? And effectively, it is clear that it's because the problem is so much more widespread. Through all kinds of social strata, rich, poor, it doesn't matter what neighborhood you're in, whether you have a job or don't, whether it's a prescription, issue, like you mentioned, hydrocodone or Vicodin, is the brand name or something along those lines, or if you're gonna, go buy balloons full or envelopes full like Philip Seymour Hoffman did, of the smack someplace off of 75 or 71 in a parking lot from a big box retailer and decide to shoot up or snort it or whatever it is that people do, it affects all kinds of people every single day. So I guess another question aside, the issue of Narcan in general, Angela Clark, is this that I have. Because I've talked to others involved, in the process of trying to save people, from law enforcement to medical personnel, and obviously Nancy Blamer from your facility also. Apparently there is a big problem, and they're trying to legislatively make a change for it, in that there is a reluctance sometimes because of fear of reprisal by way of law enforcement, where you might be shooting up with a friend because I guess it's a buddy thing. You go out and drink together. Maybe you go up and get high, shoot up together. I have no idea. It's not my thing. But so, we're hanging out, Angela, and the two of us, let's say, are shooting up. Here's a weird scenario. And all of a sudden I overdose. And you're like, oh, holy crap, Sterling's out of it. And Angela's like, I can't be a part of this. I got to go. So you bail out rather than calling for help, or you call for help and leave, because you're afraid of a situation that could be ugly, and I could turn out to be maybe, I don't know, like some type of, scenario like, Jim Morrison or something along those lines where, you get sick on your vomit. Legislative effort is being in place so that if you try to save someone in the midst of the illegal activity of getting high, you're not going to find yourself in harm's way. How much of a problem is that? Because I've talked to a lot of people who say it's a pretty big issue.
So House Bill 170 was passed in October, and it moved to the Senate. It's moving to the Senate this session. But what it basically does is it's trying to get Narcan into the hands of law enforcement, family members and friends, and emergency medical responders. And it also puts into place a Good Samaritan law that protects people from prosecution if they assist an individual who's experiencing an opioid-related overdose. So it kind of acts as a barrier. I will say we did a really holistic, systematic review of all these 19 opioid overdose prevention programs in the country, and we had, I think, a few people who had cited that they had been harassed by police, but we haven't seen anything like, for example, people who have used Narcan and then they've gotten in trouble for it. We haven't heard any stories about that.
Well, no, I didn't even mean necessarily about using the Narcan. I just mean in general. I've talked to people that have a reluctance even to pick up the phone to call for help or hang out to help. I've heard medical personnel tell me, as well as law enforcement, that you have 2 or 3 people hanging out, maybe more than that, and somebody ODs. And people panic and go, I can't be a part of this, and they leave. So then as a result of it, the casualty rate goes up, or people's life circumstances worsened, and their survivability is lessened because there's no one there staying with them because they're afraid they're going to go to jail or have a problem, which is a part of what that legislation is to be a help of. And also the way, law enforcement sometimes will just be like, look, you're doing something bad, but you did the right thing here.
Right, yeah.
So again, the Narcan thing, you're wanting to be able to have this in the hands of whom? I mean, to be able to use it. Aside from medical personnel, you've got it in ERs. You probably have a lot of it available to you at CCAT just because you're dealing with people who have treatment and issues with addiction. Who else would be using this? Where would they get it? And what would be the daily function for it, or how would this play out?
Well, so the idea is because where we're starting right now is we're trying to get it to people who are at high risk for overdose. And so that's, anyone who has an opioid dependence, we're trying to get them. We would love to see this go out to friends and families. Under Ohio law, paramedics and advanced EMTs can administer naloxone. But just now, the scope of practice has changed so that basic EMTs can use the intranasal naloxone. So we're still trying to get it out to all the EMTs.
Now, you say intranasal. Is that sort of like the flu deal, where instead of you get a flu shot, you get just a little mist, like the old Dristan or whatever?
That's exactly what it's like. There's just a nasal atomizer that you screw onto the naloxone hydrochloride, and you just put half in each nostril. It's really quick and easy. It's very easy to assemble. And it's really inexpensive. I mean, this is costing $25 to save a life.
Yeah, that's a huge difference. And the life is priceless.
Absolutely. And there's been over 53,000 people who've been trained in the United States and given naloxone, and we've had over 10,000 reversals. So we know it's working.
Yeah, clearly.
And it also provides another platform for us to get somebody in to have treatment, and we know that treatment works, and that's so important.
So this circumstance, you got a wife, you got a husband. I mean, I had neighbors a couple doors down, actually, and the family seemed about as normal, hunky-dory, picture-perfect, middle-class family, a couple of beautiful kids hanging out, reasonably well-kept house. Everything was fine until the sheriff shows up, and there's a protection order. Wife goes away. Wife apparently was a junkie, and there's all this hubbub, and they come over, hey, have you seen anything? Do you know anything? I'm like, I don't know. They had this type of circumstance. So if you have a spouse, you mentioned anybody in a circle of friends scenario, a family member, a son, a daughter, maybe even a mom or dad who has this type of problem, the idea is that you would get the Narcan or the naloxone in the hand of family members in case the scenario presents itself where there would be a fatal overdose scenario possibly able to be basically reversed as you describe it. Is that correct, Angela Clark?
That's absolutely correct. Yeah, we're trying to get it to people who are at high risk of finding someone who's overdosed. And, there's been a lot of controversy with Narcan, largely just because of, the idea that abstinence is the only approach to drug use and treatment. And there's people that think that, distributing Narcan sends a mixed message, but there's really no evidence demonstrating that this overdose prevention and Narcan distribution to people in drug treatment results in relapse. And we're actually finding the opposite. People who have received this training, because, nobody just gets naloxone. We're providing training that goes along with it. But we teach about prevention, how to prevent opioid overdoses, what are the signs and symptoms. So if your buddy's having an overdose, you can catch it early and get help and save their life. But we haven't seen anything that says that this is negative. We're seeing more as positive. People are actually report less drug use after having this training and also report higher access to harm reduction measures and treatment.
Well, Angela Clark, here's my question, I guess, to go along with it. And I want to take a break, but I want to ask beforehand, and then maybe take some calls on this as well if people are, interested. How is the demand for this? I mean, are people coming to you or their doctors, or I don't know where else even you go hunting for some type of thing like Narcan to hopefully keep a friend or family member alive who might find themselves overdosing? I mean, Northern Kentucky, just in the last week or so, there was a big story is like, what, 30%, more than 30% of people either know a family member, a friend, someone they have a relationship with who has a problem, if not with illegal heroin-type opiate circumstance, pharmaceutical opiate problems. So clearly this is a big issue. How much of a demand do we have from people wanting to get their hands on Narcan and the training for it to be able to keep the people they care about alive?
Well, so I would say the demand is great. What our program is like at CCAT is we work with inpatients. So, I mean, we only are giving it to people who have an diagnosed opioid dependence who want it, right? And that's really important. It's absolutely their choice, and it's not for everybody. So that's the only people that we're actually giving it to. But if somebody's wanting this, then this is a prescription that they could talk to their doctor about.
Okay, let's take a quick break. If you can hang, I'd like to talk to you a little bit more, maybe get a couple people in line to talk to you as well, or at least ask some questions and share some circumstance to go along with it. Angie Clark is from the Center for Chemical Addiction and Treatment. That's ccatsober.org is the webpage. Is that correct? Okay, good. All right, hang on just a minute. We'll come back, give you a chance to talk to some people as well. 749-7800, the big one, pound 700 AT&T. Those are the phone numbers. Your chance to speak your mind, ask some questions. Do you think it's time that Narcan is available for anybody who needs it? Family members, friends, of those who have a substance problem? A lot of us apparently may know openly, maybe have a suspected idea that those around us might be using or something along those lines. Your chance to get interactive straight away. More Sterling on this fine Sunday afternoon on the big one, 700 WLW. Sterling back with a woman who knows for some drugs and stuff, but she's not like a hophead. She doesn't have like an addiction problem of her own. I don't think. Probably not. Angie Clark, I know that she's all like, dude, seriously? Don't say that. She's from the Center for Chemical Addictions Treatment, which is known all over the country actually for what they do, ccatsober.org, talking about Narcan, which is this drug that basically reverses the effect of a heroin overdose, which is the body shutting down its ability to breathe, or at least remembering to breathe. Most of the time, unless you think about breathing, you're not thinking about breathing and your body just does it. The heroin sort of just ceases that function and then you go bye-bye, which is the way a whole lot of people, and most notably in the last week, literally, was Philip Seymour Hoffman. What about him? Before we get a couple of calls here real fast, has there been a greater, I don't want to say a martyr in his circumstance, but when you have someone as high profile as that, who ends up becoming a casualty of abuse and overdose, does that help with awareness and people wanting to reach out to get help like at CCAT?
I think it does. And, you know, what it helps with even more than maybe people going in to get treatment is, like, even my friends don't know a lot about heroin. Like, they would have no idea that it's an epidemic in the community. So we were talking about it yesterday, and they're like, what do you think about that? Like, I tell you what I think. I think it happened to 5 people last week in the state of Ohio. And, you know, there's another person, and it's so unfortunate, and you can relate because you've seen that person. You know about that person. But this is an epidemic, and a lot of people are dying, and it's preventable. So I think when you get that conversation started, then it really helps, you know. It helps people understand that this isn't just, you know, there's so many stigmas that go along with heroin and opioids, and it can be anybody. That's what's so important to know.
Yeah, so I mean, at least there can be maybe some positive out of something which is so sad and wasteful. In his life, not at all any more valuable to, you know, than anybody here in Cincinnati or anybody in some dark place, any place else for that matter. Just happened to be that, you know, and a lot of people, I got a bunch of email. Why should he get so much more attention and coverage with law enforcement and quick autopsy stuff? It's because he's high profile. When you have someone high profile, there's a lot more interest, but there's also a positive outcome to it as well, at least on the outside. And you validated that. Let's take a quick call. Can you do that?
Sure.
Okay, cool. Angie Clark's with CCAT, which is Center for Chemical Addiction Treatment here in Cincinnati. Greg, you're on the big one. What's up?
Hey, how's it going?
It's good, man. What's your question?
Hi, Greg.
Long-time listener, first-time caller. I got a question about, and it takes a great deal of objectivity to answer this, but what are the potential abuses of this product for a person who may try to use it to enhance a high that would otherwise be dangerous?
Right. So the naloxone, there's actually no abuse potential whatsoever. There's no real effect from this drug. And if anything, it really, like we'll talk about this with our patients, people who we say have been narcanized. I'm not sure what the proper term is, but we'll say, you know, tell us exactly what happens. They go into acute, immediate withdrawal. This is not something that they want to happen, right? This isn't something that you can abuse. And if somebody is down and you think that they've gone down from an overdose and you narc them and say it wasn't an overdose, there's no effect from the Narcan.
All right.
So it's really important to know it's very, very safe.
Solid.
And no abuse potential.
Great question, Greg. I appreciate it, man. Hey, listen, Angie, I know we only anticipated going about 25 minutes or so, but is it possible, can we come back after the news and do another segment? Because we've got a bunch of people holding who have questions for you to get more insight about Narcan and what you do at CCAT?
Absolutely.
Right.
Absolutely.
I normally
if I can
don't
answer
carry
the questions, I'd be happy to help.
All right, cool. So hang on just a minute. We'll come back after your 3:30 report. I believe Allison Wyatt has that. We'll give the Tom and Doug and Jenny and Rick and others your chance to speak your mind as well. Sterling getting it done this fine Sunday on the big one. 749-7000, 800 the big one. And if you got yourself an AT&T, it's pound 700 WLW. Big one, 700 WLW radio station, talk show host, Sterling Problem Solver. Woman in the know about drugs and such, Angie Clark. You're all that more, actually. She's from Center for Chemical Addiction Treatment, which is ccatsober.org online. Angie Clark, what exactly is your title? What is your function? What do you do besides share information with me and answering questions about opiates and addiction and Narcan specifically? Who are you and what do you do for those who would care to know? Because I want to know.
Yeah, absolutely. I'm first and foremost, I'm a nurse, and I'm working on a PhD at the University of Cincinnati, and I'm doing my dissertation research in addiction treatment, and I'm actually doing it on an opioid overdose prevention program. I'm trying to develop an education curriculum for it. And I work with CCAT as a volunteer and have a really close relationship with them. I used to take students there for their clinicals, and that's how I got to start working with them, and then now I also serve on their program planning committee, and I try and be as involved with them as I can because there's just such a huge need in our community for places like CCAT.
What have you seen in the time that you've been looking at this as far as, aside from the explosion in, I guess, attention drawn in the media associated with this, and obviously the carnage that's a part of it, which is, if it bleeds, it leads, I guess, for want of a better way to say it. Unfortunately, that's the nature of news. Oftentimes it gets our attention, and this is pretty, relative to many people and their families, whether it's their kids or their wives or husbands or relatives of any type for that matter. And a lot of people on the job, we have to see this. What changes have you seen in the last year to 3 years, let's just say, as far as either working with the Center for Chemical Addiction Treatment or in a hospital situation or in general as far as opiates or other types of substances as well? And by the way, those holding, we'll get to you. And so just hang on just a second. What about those things, Angie?
So, well, I guess what I've seen over the past year and a half is that patients, first of all, the patients that we see, they are very intelligent and have a hyper knowledge of everything about drugs, everything that they've used. They know all about it, and so it's really good to hear them talk about Narcan and what it can do, and to be open about, some of the overdose situations that they've been involved with, fatal and non-fatal, and just to get a dialogue going that I didn't hear a couple years ago.
So you're saying that you're having smarter, more well-informed junkies, for want of a better way to describe it. And I don't mean that in a derogatory term or description, but I mean that's what you just said. If I can sort of crystallize that, is that accurate?
I absolutely think it is, aside from the junkie part, right?
Well, no, but that's a derogatory term, I guess, and I don't mean it to be. But I mean, if somebody has a dependency problem, it's like saying, "Oh, I drink a lot and I can't stop." That means they're a drunk, they're an alcoholic. We are talking about people that are effectively junkies. If that's a bad term to use and that's a negative connotation, I'll stop. I won't do it anymore. I apologize. You know what
okay.
I mean? Clearly that's it. We have we have boards of mental retardation around the country, but you can't say, "Oh, Sterling's retarded," even though I might act like it. You know what I'm saying? There's that fine line. So you can't say junkie. You can say no, but you get what I'm saying. That's clearly the circumstance.
I get exactly what you're saying, and I think that's what's also really important to know is like with Philip Seymour Hoffman. He didn't look like the person that would do this to a lot of people.
Well,
right?
aside from the fact that he's,
we're trying to tell people.
Yeah, Academy Award winner, high profile, super high functioning when he wasn't apparently holed up in his apartment or whatever else, getting high or what have you. And that's the thing. I know, how I can say this. I know people that are surprisingly successful, high functioning professionals who are, in fact, I know, and have for somehow a number of years successfully maintained as much as one can an addiction to heroin. which is not the stereotypical circumstance, but somehow they maintain it. Which is, do you see that often? I'm guessing in treatment, people have seen some type of sign that lets them know that aside from, carnage and death around them or high profile death like Philip Seymour Hoffman, do you see a lot of people who somehow stay on the rails?
Yeah, we do. And this is something that affects everyone. Like it's not a social class. This affects everyone. We have physicians, we have nurses, we have advanced practice nurses, pharmacists. We have a lot, construction workers. We have a lot of people who have really normal lives, and then something happens, say a back injury or a knee injury, and they start on prescription meds, and then eventually, it changes, and they go to heroin, and then we'll run into them with treatment at CCAT. But they started out with, just like you and I, and so I think that's really important for us to know that, and that's maybe why, the term junkie, it's like we get this picture in our head that it's going to be somebody, but it is not that person, and that's what's so important. And when I take my students down to CCAT and they go and do clinicals there, it's so rewarding to see them and hear their perspective of how this is not at all what I thought of heroin users, this isn't what I thought of opioid addicts, they're shocked. But yeah, it's everyone, and it's very scary.
Yeah, it is, to say the least. That's for sure. 749-7800, the big one, pound 700 AT&T. If you have a question for Angie Clark, Center for Chemical Addiction and Treatment, which is ccat.org, ccatsober.org. If you do ccat.org or .com, I think you get some cat website or something. So it is ccatsober.org.
Sober.org.
Yeah, don't go to those. They can help you with your feline problems, but not your heroin issues. That's a whole nother story altogether. All right, this is Doug right now on the big one with Angie Clark from CCAT. What's up?
Hi, Sterling. Angie, good afternoon.
Hey.
I'm a 21-year career professional firefighter, and we seems like pass out Narcan nowadays like Halloween candy. And several points that I believe you missed on it is a chronic opioid user, not necessarily heroin, but a pain pill user. In order to give them Narcan is not always the best thing. It can have bad effects on someone who's a chronic user. And I don't know if Angie's covered that yet or not. And then my second point was the demographics that heroin users does cover the wide spectrum. However, what we see on the street is more or less the lower income type, person, and they are not necessarily highly educated, but they are street smart. And to give these people, a medication to just completely reverse it, which is what it does, and put it in the hands of someone who could possibly be having a stroke-like symptoms or a diabetic who is hypoglycemic, who's out, and lower respiratory rate and things of that nature, and, have somebody sitting there giving them Narcan and not getting them proper treatment is a recipe for disaster.
Well, what about that, Angie? Because you mentioned about requiring education before this is actually dispensed to individuals either who have the substance problem or those who might be affected by them and around them in the circumstance that, either Doug described or you did previously. Is that accurate that there is education that is a part of this? So it is hopefully not one of those misdiagnosed, mistreated, and exacerbating some other type of problem?
We do a lot of education. We do a lot of education with patients. We go over the warning signs. We talk about what an actual overdose is, and that's things that, they didn't necessarily know. And that also provides us an opportunity to teach them to not do the things that they were previously doing, like injecting them with something else to try and reverse it, or slapping them, or putting them underwater where they could drown, So we're really trying to come at this as far as prevention, provide education for signs and symptoms, warning signs, and then also how to respond. And we always include call 911 because it's really important for everyone to know that, the half-life of Narcan is a lot shorter than some of the long-acting opioids. And so It's important that they call 911 and they know that so we can get them to the hospital and get them treatment. And yeah, I absolutely don't think that this is just about heroin. Largely this increase in deaths is related to chronic pain medications, which I talked about at the beginning. So yeah, it's not just heroin. It's a lot of things, and it's a combination. It's benzodiazepines with alcohol with heroin. We call it the death triangle, and we see that too. So yeah, there's a lot going on with it, but we try and provide as much education as possible, and they always know that they can contact CCAT if they have any questions, or come in and see a counselor if they have any questions. So,
Angie, have you went out and done any time on the street and actually dealt with or monitored EMS and first responders, during overdoses and actually seen what goes on in real life and not just, in a clinical setting?
As far as actually on a crime scene, witness scene,
well, they're not necessarily crime scenes other than committing the crime of drug abuse.
You're basically talking about, have you gone out with either emergency crews when they are dealing with on the street scenarios or in the home scenarios of people who are dealing with this type of issue?
Exactly.
I have not. No, I would love to though. I would love to go along.
Oh, well, we invite you up here up this way anytime you wish. But I just think there's a lot more. For the actor that passed away the other day, it has reached, those individuals, and it is a shame. And, to put it in the hands of somebody like that or a family member, I don't see an issue with it. But I've heard of, I can't remember if it was Chicago or another big city that was basically passing it out, to users and junkies on the street. To use is just it doesn't fix the problem. The big problem is stopping it from coming into the country in the first place.
Well, yeah, and I don't know how you get that's a law enforcement issue.
That's a whole nother.
It's never going to happen. It's cheaper now than it's ever been, which is another scenario altogether. And I think it's clear that you're both looking at the same problem, but different parts of it. Clearly, because you're dealing with it every day, like you're talking about, Doug. Going out in these situations where it is a trauma scenario immediately, and dealing with different types of lifestyle circumstances to what she is, where they're coming in already looking to get treatment and so forth, but both doing fantastic things. And yeah, I mean, learning from each other what you deal with will probably be beneficial, and education's a part of it. And you're not seeing a lot of the same people who have gotten the education behind the use of Narcan or other stuff, the way obviously Angie Clark is talking about for the Center for Chemical Addiction and Treatment. Doug, great call, man. I appreciate what you're doing.
Hey, thanks, Sterling.
Take care of yourself. Maybe he's in Middletown, by the way, so maybe you can hook up with them, or maybe Cincinnati too. I mean, the more everybody knows about these type of circumstances, the better off I think we'll all be generally. What have I missed substantively that you want to get out there in regard to Narcan or opiate issues or dependency issues, Angela Clark, when we're talking about Center for Chemical Addictions Treatment, or anything else in this area before we let you hop? And I appreciate, by the way, you giving us so much time today.
Sure, absolutely. I just want to say that opioid dependence is a brain disease, and it's chronic, it's progressive, and it's potentially fatal. And we can reverse it with naloxone. And there's this vital need to expand access to these interventions that can reduce the risk of overdose, and one of those being Narcan, which is the most proximal intervention to prevent an overdose fatality. So we really are trying to get more support and legislation, and we want to include as many first responders as possible.
And obviously, I know Springdale's pushed to have this needle exchange issue. Are you guys for the idea of having clean needle exchanges? Cleveland had one of the first, I guess, in the country, better part of 25 years, and had great success with it. And as far as transmission of some communicable diseases and so forth has been quashed significantly. Are you pushing and believing that would be more beneficial for the tri-state as well, besides just Springdale, or no? Or maybe you're not capable of answering that legally for CCAT. I'm not trying to put you in a corner, but I'm doing it anyway.
Yeah, I actually probably can't answer that for CCAT. But for myself, I would be happy to say that, yeah, I'm 100% behind it, because I'm all for harm reduction measures. And, we have really high rates of hepatitis C in Cincinnati and the surrounding areas. And the cleaner we can get, the better supplies people have, then their risks are decreased, and just spreading and transmission of diseases. I think we can do so much with prevention. So I'm all for harm reduction. Aside from ccatsober.org, is there another way to get in touch, or do you just recommend the website, or what else before I let you go? To get in touch with me? Yeah. You, the organization? Yeah, also at the University of Cincinnati, the College of Nursing. I work there, so. All right. Well, listen, I appreciate your time. Enjoy the rest of your Sunday. Thank you so much. Thank you for having me. Appreciate the insight. Thanks. More Sterling straight away. We'll get to Rick, those others. Your chance to speak your mind coming up here on this fine Sunday, the big one, 700 WLW. All right. Thanks again, by the way.
Angie Clark, Center for Chemicals, Addiction, and Treatment. That's ccatsober.org. Don't go to the ccat.com or .org because it's some cat website. Felines, I mean, like kitty. Yeah, don't. And I've issues with cats lately. No rabies shots required. By the way, that's good. That's good for me these days. Anyway, so good talking to her. By the way, coming up after the news at 4:06, we will get into the mind of one Vanny Hari or Harry. I'm not sure how it's pronounced actually. She's foodbabe.com, the woman behind it. About this Subway thing. Subway's changing their bread for their sandwiches. Apparently, a lot of people are upset for some reason. I don't know. The bread seems fine, but we'll find out about that. Some genetically modified stuff, things to worry about in the food and disclosure. Because apparently, there's a lot of big companies and so forth that do, make the stuff we eat. And it's good. I like to eat. Eating is good. But in the same respect, they're not necessarily for full disclosure of what's in the stuff they're feeding us. And that seems kind of weird to me. And I don't know if it's because what's in there is bad for us as much as what's in there might make us reluctant to eat it and then would hurt their business. And I'm kind of in that point of, well, if it's not something that we want to know about because it might scare us or it might be bad for us, maybe it doesn't need to be in there. We'll find out what the deal is with her coming up after the news 4:06. So there is that other stuff to get to as well. A bunch of weird things, puppies and breastfeeding moms and just weirdness to say the least. Rick's been holding on forever and a day on the big one with Sterling. What's up, Rick?
How you doing there?
I think I'm all right. What's up?
Yeah, listen, I want to ask a young lady, how much is that Narcan? Is that free or... And also, when someone has to stay short term in one of those care centers, how much is that? And is that covered by like Blue Cross Blue Shield health insurance? And how will Obamacare affect it? Those are the main questions I have.
Well, she's actually gone now. I'm not sure exactly the cost associated. I think it's like a prescription that you would get for this medication, is my guess. You can check out the website, by the way, ccatsober.org. They might be able to help you with that. And as far as medical care coverage for in-treatment facilities, it depends probably on your coverage. I don't know how much is required by Obamacare. In that regard, there are now, obviously, as a result of the Affordable Care Act, commonly known as Obamacare, required to give like basic healthcare services now as far as like preventative stuff and like oil changes for humans effectively and those type of things that you'd normally have a copay for. You're required to give you those as a part of your plan no matter what. Now, I think whatever time, once or twice a year or whatever. So there may be some variances with that as well. I think CCAT, for that matter, does some stuff, and I think a lot of theirs is free. For that matter, as far as in-treatment stuff and even the short-term residential, but there are some requirements to go along with that. And I know demand, obviously, not just in the tri-state, but around the country, for that matter, is gotten much greater for whatever reason. We know why in the tri-state. The rest of the country, I don't know why everybody's loving the smack so much, but it's a growing concern for whatever reason. I don't know why. Did I cover it? Yeah, go ahead.
One more question. Has there been a paradigm shift in the use of heroin over the last 30, 40 years? It used to be, remember back in the old days, this was, well, if you start out on the lighter stuff like herb or marijuana, and then you will gradually progress on the harder stuff like heroin. Has that paradigm shift, has there been a paradigm shift in that?
Well, everybody that I've talked to, I've had tons of experts on here and elsewhere over the last couple of years, especially in regard to this. And people say the gateway drug could be cigarette, nicotine, to drinking, to, to weed, to whatever. Everybody's different. Not everybody, some people can just smoke their weed or have their drink and they'll be okay. Other people keep wanting to taste something new. They've got that gene also that won't let them let it go. But what has changed is the cost. It's way cheaper now for heroin. And there's been a lot more problem in relation to OxyContin back in the day, the hillbilly heroin, and a lot of dependency issues with the pharmaceuticals. And then they tightened that up, at least in the tri-state, as far as getting prescriptions. So then, therefore, the people who have dependency issues have gone out to get that heroin, because they still need to get that fixed somehow. I can't speak for the rest of the country, but that's what everybody that I've talked to in the tri-state has said, and that's for Ohio, Indiana, Kentucky, West Virginia, this whole area for that matter. Rick, good call. As always, good to talk to you, my friend.